All right. Hello, everyone. Thank you for joining us for the Foothill College COVID Vaccine Education Series presented by the STEM Division and Science Learning Institute. My name is Ram Subramaniam. I serve as the Dean of the STEM Division at Foothill College. This is a four-part series to learn about different aspects of the COVID vaccine. The biology and public health information was what we talked about the last 2 weeks. Today, we'll talk about the myths around the vaccine, and next week, we'll finish it up with some information from our county health office. Sophia Kim, Rebecca Ryan, Diane Denagel, and Sarah Cooper are the co-organizers of this program. I am handing over to Sophia Kim, who will go over some of the logistics regarding this webinar.
Thanks, Ram. Hi, everybody again. Good to see, hopefully, some repeat comers and new people as well. I'm Sophia, the director of the Science Learning Institute, and just going to review a little bit of logistics for our webinar today. You might notice that the chat box has been disabled, and this is just to limit distractions for both our participants and our speaker today. You will be able to use the Q&A box, which you'll find at the bottom of your screen. Please feel free to add your questions as they come. You'll see that there's also an upvote option. So if you don't want to repeat yourself with the same question that somebody else asked, you can just click on that thumbs up. The webinar, as the previous two, will be recorded and posted at our COVID Education Series website. I'll post that in the chat box. You can find that link, and hopefully you use that to come to our webinar today. Hopefully the recording will be up by the end of the week. And finally, we have our two ASL interpreters with us today, Alicia and Debbie. Will have their screens pinned for those who require the interpretation. Back to you, Ram.
Thank you, Sophia. It is with great pleasure and honor that I introduce today's speaker of this education series. Speaking today to us about the myths around vaccines is Dr. Peter Hotez. Dr. Hotez is Dean of the National School of Tropical Medicine and Professor of Pediatrics at the Molecular Virology and Microbiology Institute at Baylor College of Medicine, where he's also the co-director of the Texas Children's Center for Vaccine Development and Texas Children's Hospital Endowed Chair of Tropical Pediatrics. He's also university professor at Baylor University, a fellow in disease and poverty at the James A. Baker III Institute for Public Policy, senior fellow at the Scowcroft Institute of International Affairs at Texas A&M University, faculty fellow with the Hagler Institute for Advanced Studies at Texas A&M, and health policy scholar in the Baylor Center for Medical Ethics and Health Policy. Dr. Hotez has authored more than 500 original papers and is the author of 4 single author books, including Forgotten People, Forgotten Diseases, Blue Marble Health, an innovative plan to fight diseases of the poor amid wealth, Vaccines Did Not Cause Rachel's Autism, and a forthcoming 2020 book on vaccine diplomacy in an age of war, political collapse, climate change, and anti-science. Dr. Hotez is running a couple of minutes late, so as we wait for Dr. Hotez, we're going to watch a little video that shows some of his work till date.
And Ram, since when I'm sharing my screen, I can't see anything. If he comes in, just ping me and I'll stop the video.
Out there on the internet that either me or Bill Gates are using the vaccine to implant chips in people, and it's just an outlandish conspiracy.
There is no need for vaccination because we live in a country where certain preventable diseases are no longer widespread.
That's false. All these diseases can come back, just like we've had terrible measles epidemics across the United States last year.
Vaccines are not 100% effective.
That's true. Most vaccines are not 100% effective, but they're pretty good. So for instance, one of the best vaccines we have is the measles vaccine, in which 2 doses of the measles vaccine is 97% effective.
Vaccines cause infection.
That's false. Vaccines are designed to prevent the infection.
Vaccines cause autism.
All of that has been proven to be false. There's absolutely no link. We know what does cause autism. There are at least 105 genes involved in early fetal brain development.
A person is immune to the coronavirus right after vaccination.
That's false. It takes usually a week or 2 to develop an immune response against the vaccine.
Vaccines are safe and effective.
That's true. Vaccines, any vaccine that's licensed by the U.S. Food and Drug Administration has to be proven to actually work, protect against the disease target it's intended to, and it has to be proven to be safe.
Got a lot of questions in there, didn't we? Our Verify team is here to help you separate.
That was it for the video.
Thank you, Sophia. So as we're waiting for Dr. Hotez, we have our panelists from our previous 2 weeks, Sarah Cooper, as well as Rebecca Ryan here with us. Did you want to update us on any new information that we have about the vaccines?
Hi, sure, I can talk a little bit. There's actually been some kind of good news about vaccines just in the last—
looks like we have Dr. Hotez here with us.
Excellent. We'll let him talk.
Hi, I was watching that video, but I couldn't get access.
Thank you, Dr. Hotez. Welcome. The floor is yours. We've already introduced you to our attendees, and it's all for you to take over from here.
Well, what I'll do is, why don't I just speak for a few minutes about where I see things are heading in the United States and globally, and then we can open it up for questions. Does that sound like a good approach? I mean, I'm in your hands, so.
That sounds perfect. Thank you.
Okay. Well, you know, what we're seeing now is a kind of a race between this new variant, the B.1.1.7 variant that's been accelerating across the country, which is more transmissible than variants that we've seen in the original lineage that we've seen in the past. And it's causing higher morbidity and even mortality among younger people. So that's extremely concerning. And that is accounting for that big surge that we saw in Michigan over the last few weeks, in the upper Midwest and the Northeast. The good news is that we are now rapidly progressing in terms of our ability to vaccinate. We've got about 45% of the U.S. population has received a single dose of the vaccine, and almost 30% has received 2 doses of the vaccine. And we may start seeing some declines now as a result of vaccination. And so the truth is, we have had other declines in the country before, but not due to vaccination. This is now we're seeing the first evidence of decreases in transmission because of this. And I think New Hampshire may be our first sign, our first ray of hope. It's a small state, admittedly, but we've achieved 60% coverage of a single dose. And that benchmark is important because when we hit those numbers in Israel, we started to see significant declines in Israel. Now, the difference in Israel is they were so efficient at the second dose that they've got 60% of the population with a single dose and 50% with 2 doses. Then the numbers really started to plummet. So I suspect that as we hit that number, those numbers in the United States, we'll do the same. So for instance, in San Francisco, where about half the population has received a single dose, I would expect we'll start seeing some significant declines there. So there is a glimmer of good news. The problem is things are uneven across the country. So we're seeing more than 50% of the U.S. population getting a single dose in the Northeast, up in New England, in California, and New Mexico. And we are seeing certain states, especially in the South, such as Alabama, Tennessee, Louisiana, are way down. Only about a third has received a single dose, and the same for some of the mountain states, such as Wyoming and Idaho. So the other odd trend that we're seeing is kind of a blue state, red state divide, and no one likes to mix science with politics, but that is a reality that we are seeing this a split in the country in terms of who's getting vaccinated at high levels and who's not, and we're trying to understand why we're seeing that blue state, red state divide. In part, it's we do have 4 independent news polls now that confirm it. So the PBS NewsHour did a poll, Monmouth University did a poll, Quinnipiac College did a poll, and Kaiser Family Foundation did a poll, and they're all using different methods, all more or less came up with the same thing, that about 40 to 50% of a group self-identified as Republicans will refuse COVID-19 vaccines. And so that's a problem. And if we're going to seriously vaccinate our way out of this epidemic, we need a high level of vaccination across the country, and we need it to be consistent. And the exact number that we need to actually slow or halt virus transmission varies depending on different individuals' estimates and the assumptions that you use. But with this B117 variant, we'll need at least 3/4 of the U.S. population vaccinated, and maybe as high as 80%. And that's a very high bar, because at least 15% of the population off the bat can't get vaccinated because they're ineligible because they're too young. So we don't have, it looks like no vaccine will be approved or either released for emergency use authorization or approved in kids under the age of 12. I don't think by this year. We might, I think in the next few weeks, we'll have, or maybe even by tomorrow, we'll have information about adolescents age 12 to 15. But we still have that segment right off the top of little kids that are not going to get vaccinated. So that means we pretty much have to vaccinate all the adults and adolescents. And so I think reaching out to conservative groups is going to be really important for us to achieve that goal. I think another piece that we have to think about is there's still a lot of transmission going on in Canada and in Mexico, and we need more to halt transmission there. So I think we have to help our Canadian and Mexican brothers and sisters get vaccinated. So that's where we're looking at in the U.S. Right now, the other variants of concern are not really accelerating in the U.S., maybe with the exception of the one from New York, the B1427, and I'm sorry, California and New York 1427 and 1526, which is the New York one. The California is 1427. But other than that, I think we'll be okay. We should expect that variants from South Africa, the 1351, to be a problem, the Brazil P1, and then the Maharashtra coming from India, the 1617, to be problems later on. And for that, we'll need booster shots. So if you got 2 doses of the Moderna or Pfizer vaccine, expect a 3rd dose sometime later in the year, next year, that'll be specifically configured for those variants of concerns or some type of hybrid variant or concern. And that may be about it. I don't know that we'll necessarily need to vaccinate every year. But then we have this terrible problem globally. I mean, the issue is, in terms of countries that are vaccinating as well as the U.S., the UK, Israel, a couple of Western European countries, but that's about it. The other countries in Latin America, Africa, and the Middle East and parts of Asia are falling behind significantly. So of the almost billion doses of vaccines that's been produced so far, overwhelmingly it's in the US and China, accounts for about half of it, and the Chinese have their own locally produced vaccines, and European countries, and we're doing a terrible job in terms of Africa and the low and middle income countries of Latin America. And this is going to be a crisis because this virus will continue to accelerate. We'll continue to see new variants emerge. And right now, we don't have the vaccine doses to provide for them. So the RNA vaccines are problematic in terms of scale up. We don't have the billions of doses that we need. If you think about the numbers, We have 1.1 billion people in sub-Saharan Africa, 650 million people in Latin America. We have hundreds of millions of people in the low-income countries of Asia, at least 2.5 billion people. Times 2 doses, that's 5 billion doses of vaccine. So where's that going to come from? So one of the things we're trying to do is accelerate our low-cost recombinant protein vaccine that's being scaled up right now in India by our collaborators at one of the big vaccine producers known as Biological E. And they are also scaling up production of and filling and finishing the Johnson & Johnson vaccine. So we hope that those two vaccines can really make a difference in the world. And also Serum Institute of India is producing vaccines. So they are producing the estimated 1.6 billion doses of vaccine that'll be needed to quell the epidemic in India. So we hope our vaccine could have an important role. But we are also counting on India to vaccinate the world. And that's a problem because right now Prime Minister Modi has put an embargo on exporting vaccine to other countries, and that's really problematic because we were counting on India to provide vaccines for the world. So exactly how that works out is still remains to be seen. So we have a good news, bad news story. Good news for just a select number of countries, including the United States, but we're not even close to vaccinating our way out of this pandemic. So maybe I should stop there. I know I've said a lot, and then we can do the rest as kind of a Q&A.
Yeah, so Dr. Hotez, thank you for that. And one of the questions that's very big on all of our minds at the community college here is whether or not we should be requiring or mandating that our students and employees at the college district should be vaccinated. So how would you respond to a question like that?
Yeah, I'm trying as a general rule, I'm trying to go lightly on the mandates because when you talk to conservative groups, that's one of their biggest concerns about vaccine mandates or requirements. And you're already seeing in Governor Abbott, for instance, in Texas, has issued an executive order saying no mandates, and legislatures in Arkansas and other GOP stronghold states are saying they're going to try to prevent any type of mandates. And so I said we have to be very careful about how we do that. I personally think colleges and universities should be vaccinated. When my youngest son went off to the university, he had to show proof of his meningococcal vaccine, his meningococcal B and his ACWY. I think that's reasonable. So I think that's one of the exceptions. I think hospitals are potentially an exception as well. But beyond that, I think if we push too hard, it could be counterproductive for us because the conservative groups will see this as kind of a battle cry, as another reason to be defiant, and would ultimately be counterproductive.
Sort of related to that, the college students are in that age group that tend to be generally healthy, unaffected by COVID in comparison to many other age groups of people or populations. So how would we encourage our college students in that demographic to go get vaccinated?
Well, as we all know, Joe Rogan said last week, if you're young, healthy, and fit, I wouldn't recommend vaccinating. And that was a sort of a paraphrase. And I disagreed with him. And the reason is this. And I know Joe Rogan and like and respect him. I think the issue is he's not aware that this B117 variant is not your father's COVID-19, not your mother's COVID-19. It's different. It's more transmissible, and it's causing a lot of young people to go into the hospital. So a lot of young people are getting sick with this variant. And even if you're not being hospitalized in the ICU or losing your life, we know that about 30% of young people are getting long haul symptoms. They're getting shortness of breath, palpitations, inability to exercise, which is so important for young people. They're getting what's called brain fog. They can't concentrate, and also unipolar depression. So COVID-19 is a bad actor even among young people, and I think that's a message that really hasn't gotten out as much as it could.
Thank you. Another question that comes up is about the approval of the vaccine. So since the current vaccines that we have are emergency approved and not necessarily through the regular approval channels, the question here in our Q&A is, how do we explain that these people to people that or convince them to take the vaccine despite the methods by which the vaccine was approved?
Well, the approval, the emergency use authorization is really not much different than a full approval process. The difference is with a full approval process, we try to collect a full year of safety and efficacy data before we issue what's called a BLA, a biologics license application. In this case, if we waited a full year, given that we were talking about thousands of Americans losing their lives every day, when you add up the number, you're talking about 1 million Americans who have lost their lives on top of the devastation we've seen already. So the point of the emergency use is to do that after 2 months of safety data, and knowing that if that most safety signals would become obvious by then, but continue to follow it. So I think what's not understood is that even after these vaccines are released for emergency use, it's not like we're done. We continue to follow them very closely through a carefully orchestrated process of what's called pharmacovigilance, meaning vaccine events, vaccine advents, adverse events reporting, or also one's called Vaccine Safety Data Link. There's about 4 redundant systems in place. So that's being followed very closely. And we know it's robust because that system was able to pick up a very rare safety signal. And that, of course, was the cerebral thrombotic events that are occurring 1 in 100,000 among young women with the J&J vaccine. So I think people can take comfort in knowing that we've got a serious system in place for picking up even rare events. And so far, the safety profile of these vaccines looks quite good.
All right, thank you. A question that's come up sort of almost every time we've done this education series is, can you still transmit the COVID after receiving the vaccine?
So what happens is those vaccines induce I've been talking all day, induce what are called virus neutralizing antibodies. And those antibodies not only keep you out of the hospital, but they seem to dramatically reduce transmission up to 90% or more. And so that prevents you from shedding virus. So it doesn't mean you can't. It's just that the amount of virus shedding is way down and much less in vaccinated individuals. So that's why if you're vaccinated and your friend or relative is vaccinated or your significant other is vaccinated, you could be in the same room together. The likelihood is you're not going to transmit virus. And because these vaccines are good at both stopping symptomatic illness as well as reducing virus transmission, it means that as we fully vaccinate the population, we'll actually halt or dramatically slow virus transmission. So if you're vaccinated, you're not going to give people COVID-19 or it becomes much less likely. It never goes down to 0, but it's about as good as we can get.
So I read in the paper this morning that the term that we often keep referring to, herd immunity, is now several months out because of the hesitancy of lots of people to get vaccinated. So how will this sort of hinder the full reopening of cities and places from sheltering in place as we know it?
Well, honestly, I don't even use the term herd immunity anymore because it's been so corrupted by groups that want to use it as a means to prematurely relax social distancing and masks. And they come up with these fake numbers saying herd immunity is after 40%. It's nothing like that. So what will happen is this, as we get above 60, 65% vaccination coverage, transmission will start to go down and start going down quickly. And that's what we've seen in Israel. We're starting to see in New Hampshire now. Once we get above 70 to 75%, it's going to go really down, and to the point where it won't disappear entirely. Again, it's not a light switch, but we will see the point where there'll be so little virus transmission, if enough people are vaccinated, our life can start to resemble something that looks like what it did pre-pandemic, which means, having in-person classes, going to restaurants and bars and clubs and sporting events and weddings and family events, all that good stuff, with one exception. And the one exception is we can still do domestic travel, but international travel to many parts of the world will still be treacherous because we've not done anything to stop virus transmission there.
Got it. Thank you. A question in the Q&A is, we're in a race with the new variants. Pfizer and Moderna were developed during 2020. How can you say these vaccines help?
Well, we know that the vaccines developed against the original lineages seem to work just as well against the B.1.1.7 variant, which is the dominant variant now in the United States. Even though it's more transmissible, the vaccines work just as well. So that's good news. They do not work as well against the South African and Brazil variant. Right now, they still partially protect. Those are not here in a big way in the U.S., and so I think it's likely we can expect, in order to handle those new variants later on this year or next year, we'll need a booster shot. So if you got 2 doses of the Moderna or Pfizer vaccine, expect that you're going to get a 3rd dose of a vaccine. Or if you got a single dose J&J, expect a 2nd dose. And what that'll do for you is that will elevate virus neutralizing antibodies even more and give you more durable protection. And they'll be specifically configured for the new variants, because they'll be modified to make them more specific for some type of consensus or hybrid variant. And that's the way that'll get handled.
And in the chat Q&A, there's a related question as to when we could expect these types of booster vaccines.
I don't know exactly. I think by the fall, in some cases, possibly next year. It depends on the level of additional testing that the Food and Drug Administration is going to require.
Okay. And how about the vaccine for people under the age of 16, so for children? And
so now I think very soon, maybe in the next few days or definitely by the end of the month, I think we'll get emergency use for the Pfizer-BioNTech vaccine for 12 to 15-year-olds. And that'll be great because that means that we can have middle schools and high schools fully vaccinated, both the students and the teachers and the staff. I think for the little kids, that's going to take longer. There's going to be some extra safety studies required, and it won't move as quickly. So I don't think we'll have the data to support emergency use authorization for little kids by the end of this year. It's possible, more likely next year as well. But if virus transmission's way down, then we could still open up elementary school safely as well.
Got it. Another question is, what do you say to people who have tested positive, had minor symptoms, and believe they are now immune? Why should they get the vaccine?
Well, they will have some degree of immunity, but it's incomplete, especially against the variants, and not as durable as getting vaccinated. So by vaccinating on top of having an infection, that infection almost acts like a first dose of vaccine, and you'll get a pretty big boost. So much so that some people have said, well, if that's the case, why don't we just use single dose vaccine for people who have been infected and recovered? And in Prince, and people like my friend Eric Topol at Scripps Institute has made that recommendation. And in principle, he's right. It probably would. The problem is operationalizing it, because, imagine you have a line of people in front of a large football or baseball stadium, you're getting vaccinated. How do you operationalize that? How do you determine, okay, who's been infected previously? How can you confirm it with antibodies? Showing the pre-existing previous infection. It's too hard to do it. We just can't handle that level of complexity in our health system. And so I think that the thinking is just give the go ahead and give them both doses of the vaccine. It won't do any harm. And in France now they're trying to operationalize it, and they have a much more nationalized and unified health system, and even they're having a lot of trouble doing it.
Got it. There are two sort of related questions about some of the myths around the vaccine. One person says, what are some of the common myths circulating about hesitant populations and the truth on these issues? We know from communication studies that just hearing the facts won't change folks' mind, but the equipping us to listen to them and expound on their thoughts and address specific concerns might help chip away at the problem. And another person asks, there's just so much doubt in women, especially related to fertility. The vaccine can affect your fertility. So pregnant women were not included in any of these vaccine trials. So how do we respond to these types of issues that are coming up for people?
So remember, with the infertility assertion, that was based on fake information about the HPV vaccine for cervical cancer and other cancers. In other words, the anti-vaccine groups, after I was partly successful in debunking the fake claims that vaccines cause autism, the anti-vaccine lobby looked for other fake things to allege. And one of them was that the HPV vaccine for cervical cancer and other cancers caused infertility as well as autoimmunity. And it was complete nonsense. And we have the data to say that it's total nonsense. So what the anti-vaccine groups do is they can be pretty lazy. So they just take the fake assertions about the HPV vaccine and copy paste it onto the COVID-19 vaccine. That's exactly where it came from. There's no evidence that that's the case. And in the pharmacovigilance data shown so far, that seems to be, and there's not even any plausible mechanism for it. So this is the problem, that the anti-vaccine movement started as kind of a fringe element, but now it dominates the internet. The Center for Countering Digital Hate now finds that the lead anti-vaccine groups have more than 58 million followers on social media sites. So they're just dominating the internet. And then you also have now, as I said, this political shift to the right coming out of conservative groups. So they're a leading vaccine hesitant group. And if you've watched Fox News the last few weeks, you've seen the evening anchors just go on these anti-vaccine rants, and they'll target me and other scientists. And that's a problem. And then because that's not complicated enough, we now have reports from US and British intelligence showing that that the Russian government, the Putin government, has launched this whole systematic program of what's being called weaponized health communication to discredit COVID-19 vaccines produced from the West in favor of Sputnik V, their own vaccine. So all this stuff is causing a lot of damage. So when I hear someone, make some fake assertion about infertility or genetically modified humans or 5G, I have some sympathy, because they're so inundated with garbage, they're so inundated with misinformation that they're more likely, if you do an internet search, more likely to get misinformation than real information. And it's because we've not been willing to take a more confrontational approach against anti-vaccine groups.
Thank you. There's a question here which goes back to one of the first questions that I asked, and you already addressed, but it seems to keep popping up. At what point should the state or federal government step in to require vaccinations?
Yeah, as I said, I would hold off. First of all, I don't think the federal government will. I don't think they're going to touch it at any point soon. I think you will see some businesses require it, but I think that's how it will go. I don't see a federal mandate coming in part because it's just, again, poking the bear, meaning that it'll give anti-vaccine groups another rallying cry and conservative groups, and cause more defiance, and it will accelerate that red state, blue state divide that's already so damaging for the country.
Since we are here at the college, could we ask, what should be some of the most important things we should consider as we start bringing classes back to campus? What should be our focus in terms of our efforts to bring our students back to campus?
Well, the best way to do that safely is, as I said, one of the few exceptions of vaccine mandates are college campuses. We already have now 100 universities and colleges across the country requiring vaccinations. I think that's a very reasonable step to take to keep the faculty, the staff, the students, not only the faculty, staff, and students, but all the local businesses around there that students are sitting in cafes with their laptops, having coffee. That's a risk for the proprietors of those businesses as well. So I think that would be the one most productive thing you can do, I think, is requiring proof of vaccination for opening up the college.
That's really good to know. I mean, this question is going to come up, I think, very soon, maybe even tomorrow. One person asks, will the US government issue international vaccination certificates? I guess sort of like the vaccine passports that you hear from Israel, for instance.
No, as far as I know, they are not. On the other hand, for international travel, some countries will. So, like for instance, when I do a lot of work in Brazil, when I go to Brazil, I have to provide proof of my yellow fever immunization or when I want to get my visa. And it may be that if you want to go to England or if you want to go to Western Europe or Israel, you have to show proof of vaccination. And I think that's how it'll work more than anything else.
Got it. Thank you. At any point when if you run out of time with us, please let us know because we can keep asking you lots and lots of questions.
Well, I'll sign off at the quarter hour, so in 8 minutes. So
we'll take whatever we can get. Thank you so much. Here's a question that says, my friend experienced muscle spasms for 2 days after his second dose. There's been some studies that show a link between low magnesium levels and severity of illness. So I'm wondering if perhaps low magnesium levels equate to severity in vaccine side effects.
Yeah, I've not heard anything about that. What I do know is that these vaccines do cause a lot of local inflammation, and especially after the second dose, you can feel sick for 24 hours or 12 hours. And for instance, 24 hours after I got my second dose of the Pfizer-BioNTech vaccine, I had shaking chills that evening. And that's a sign that your immune response and your inflammatory response is kicking in. So one of the things I recommend is when you get vaccinated, don't plan anything ambitious for the next 24 hours. Don't try to plan a big presentation or a major exam that you have, and keep your workload light that day. Try to get a good night's sleep and recognize that you may feel fatigue, you may have headache, you may have low-grade fever, you may have some chills, you'll have muscle aches and pains for that period of time, but that's it. I mean, the vast majority of people handle it quite well.
And should we estimate that window of time for the side effects to be about 24 hours post second vaccination?
That's what it was for me, but it varies. I would just say, maybe up to 36 hours, just kind of keep it light.
Okay. Another question, this is also a little bit repeat, but I think it's worth looking at it again. If people have acquired natural immunity from contracting COVID-19, why are they still recommended to get the vaccine?
Because the vaccine you get from the infection is not very durable and it's inconsistent. It varies depending on how your severity of illness, and it may not do a good job of protecting against variants. So to assure all those extra things, that's why getting vaccinated really does make a difference, even if you've been infected and recovered.
And sort of related to that and to reopening of the school campuses, should we be concerned about breakthrough infections?
It's possible. You remember, even the vaccines, as good as they are, 95% protective, are not perfect. So there have been breakthrough infections. They're uncommon and they're of much less severity, but they can occur. There'll be less of a problem as more and more people get vaccinated. Then there's less virus circulating. So I think the frequency of breakthrough infections is really going to start to decline as well.
Okay. So a thing about community colleges, though, which is a little bit different from four-year schools and universities, is that four-year school community colleges do not require any vaccinations as a condition of enrollment. Would your answer change based on that regarding to what we should do locally in order to reopen our campus?
Yeah, I mean, the reason, for instance, you're doing the meningococcal vaccines is because there's kids in the dormitory and there's a lot of close contact, and we know that's a problem. And with your community college, not only do you not require meningococcal vaccination, you probably don't have a lot of dormitory living either. I think the reason to justify it is going to be protect you're still have a lot of students in class, and you still have a lot of teachers with risk factors, either because of age or underlying comorbidity. So there's no question that for safety of staff and teachers as well as the students, there's still a good reason to go ahead and require that vaccine. The other thing I've been saying is if your college is in a group, as an administrator, it's probably good if you all agree to the same practice, because that kind of sets you up for a problem. So if you're in a consortium, for instance, of community colleges in the Bay Area or wherever you are, it's more helpful, I think, if all of you are on the same page and do more or less the same thing, because otherwise people are going to come along and say, how come that college isn't doing it, but you are, either way or the other. And I think it puts you in a more compromising position. So for instance, I've been asked to advise a number of the colleges here in the Houston area, and I've basically said, look, it's easier if Rice and University of Houston and University of St. Thomas and Baylor College of Medicine all more or less do the same thing, and it just makes it easier to explain for people to understand.
Excellent. Thank you. Yeah, and we are a large group of community colleges. We are a sister college district with one or two colleges in our district, but then there's the whole Bay Area region, which has around 10 community colleges, and our students frequently move from one to the other.
That's right. And I imagine you're on Zoom calls with the leadership of those colleges on a regular basis. And so if you can harmonize that, it works to everyone's advantage.
Thank you. Thank you. There's an interesting question here, which says, none of the articles I have read seem unbiased. They have seemed like they were intentionally trying to manipulate people through fear. Can you recommend a reliable source for information that is informative, but not overly persuasive or manipulative?
Well, yeah, I mean, this also comes a lot out of the anti-vaccine groups, is because as they lose the arguments on scientific grounds, they try to make emotional appeals and say that, the articles are manipulative, and that's part of the problem. I mean, anything that you see on the CDC website, Centers for Disease Control, is reliable. The problem with the CDC website is it's often not easy to mine and find the information. I mean, I know where to look, but I have an MD and a PhD, and for the general public, it's not so straightforward sometimes. But the CDC is a source of reliable information. Other places in terms of reliable, I found the New York Times quite good, both in terms of their vaccination tracker and their COVID counting. It's derivative in the sense that it builds off Johns Hopkins websites and others, but it's good one-stop shopping for quick information.
Okay, that's useful to know. During the 2-week period after your second vaccination, is it still possible for you to become infected with COVID?
It is. It's even, and well, certainly it's possible for you to become infected with COVID after a single immunization. The protection tends to go up more with time. So in the immediate, but after 2 doses, the immune system doesn't fully kick in until about 10 days to 2 weeks after the second immunization, and then you're good to go. So if you've gotten 2 doses and don't plan on flying, 2 days after you've gotten your second dose, that's probably not ideal. Give it at least a week to 10 days, preferably 2 weeks, and then immunity is going to increase significantly.
I want to end with this sort of fun question at the end, which asks, what are your thoughts on Tucker Carlson saying that people should call the police on kids wearing masks outside? I know it's not fun. I mean, not
yeah, I mean,
fun, but...
well, first of all, and then what's her name? Laura Ingraham went after me. She put up a picture of me with Tony, Fauci, and Vivek Murthy calling us I forget what she called us, the medical merchants of doom or something like that. It's not helpful. And well, of course, Vivek and Tony, they get Secret Service, right? They get 4 ex-University of Oklahoma football players walking behind them with earpieces, and I have Ann, Rachel, and the cat, so it's not quite as fair. But what I say is, look, this is not coming from Tucker Carlson, it's not coming from Laura Ingraham. This is concerted disinformation coming. That this is an executive decision being made by Fox News or the Murdoch family. And what their motivations are, I don't know, but it's causing damage, and trying to do whatever I can to go back on those shows and work with them to provide accurate information. But so far, because I was on Fox News quite a bit at the early part of the pandemic, and then they went in a different direction, and trying to bring them back and would be really important, I think, especially because we know conservative groups are the most vaccine hesitant groups right now.
Yeah. So thank you so much, Dr. Hotez. We're at the quarter of the hour, and this has been so valuable as we think about all the different things to ponder as we plan our reopening of our campus for the fall. So thank you very much for your time. We are
well, thank you, and thank you for all your great work that you're doing, and let me know how things go. And these are moving goalposts, so we never know exactly where this is going to head. So if I have to come back in 4 or 5 months, that's fine too.
Absolutely. We'll definitely take you up on that. And we have our panelists here from our previous talks as well. Sarah Cooper spoke with us about the biology of the virus and the vaccine, and Rebecca Ryan spoke with us about public health context related to the vaccine. And this is the third of the 4 talks. And next week, we're going to hear from our local county health officer's office. So thank you very much for being a part of this.
Oh, thanks again for inviting me, and good luck.
Thank you.
Bye-bye.
And Ron, we can answer the other questions that are here if people still want that. Sarah, I don't know if you're still here. Yay.
Sure. Yeah, let's go through some of these other questions. And I didn't get to all of them because some of them were repeats and people might have joined in a little later in the talk. So let's just go from the top here. And if you had not had any reactions to the virus, is there a concern that this is not effective? I'm guessing if you've not had any reactions to the vaccine, did the vaccine still work?
Yeah, so I can touch on that, and actually the question below that too about side effects. So what we know about the immune response is that the side effects that are coming because you get the vaccine or because you're generating an immune response. But we also know that if you don't see those side effects, the immune response is still there and is just as strong. So when we go and we look at the number of antibodies that are produced, when we go and we look at the amount of protection and how quickly it develops, it's the same. You should consider yourself lucky if you don't get the side effects. But on the same token, if you are seeing side effects like the itchy bumps or the inflamed lymph node or achy joints or any of that kind of stuff that can happen. Yeah, that can really happen anytime from a couple of hours after the vaccine to several days after the vaccine, that those are natural responses of your immune response or natural parts of the immune response and are to be totally expected. And we do see, especially with the second dose, a lot more of those side effects. At that point, you can just kind of give yourself a little hooray because your immune system is definitely working. And if you are one of those people who doesn't get the side effects, then you can pat yourself on the back and think your immune system's working without making you sick. So
that was me. Another question, I think this already was answered by Dr. Hotez. Maybe this person joined in late. What are your thoughts on Joe Rogan saying healthy people should not get vaccinated? Either of you recall what he said?
Yeah, he definitely was making an association, I think, with understanding that it is true. The rates of infection among young people, as far as like hospitalizations initially when it started, were people were seemingly not as affected as our older populations, 50s, 60s, 70s. However, the B.1.1.7 variant, the UK variant, that's the predominant variant in the United States. One example, look at Oregon right now, look at Michigan, look at the rates of young people that are being hospitalized and having poor outcomes. And that's a very different contrast than the types of virus that were presented here in 2020. Also, remember, young people are huge sources of infections. They're vectors of infections. So ignoring the fact that young people may not have as significant poor outcomes as the older population did when the pandemic started ignores the understanding of the vaccine and how much a vaccine is not only about you, but it's about protecting all the people around you and keeping that going. And I remember Sarah saying, and please jump on this, Sarah, about how the more that the virus circulates, the more opportunity for variants. So getting lots of people vaccinated helps to stop that from happening.
Yes, I remember that cartoon which Sarah showed us in the last couple of weeks ago. So 2 questions for you, Sarah. One, back to the side effect issue. If you don't experience any symptoms after getting the vaccine, does this mean you may have already been exposed previously? And then after you answer that, the other question was, just before Dr. Hotez came on, you started by saying, I have some good news. And so I think people are dying to know what the good news is.
I'm just building suspense. I'm trying to make you stay logged on until the very end. So a couple things about the side effects. So I've actually heard people say both ways. Like, if I get super sick after my first vaccine, does that mean that I've already been exposed because I'm feeling those bad side effects? And I've also heard that if I don't feel any side effects after the second, does that mean that maybe I've had it before? And I think the answer to that question is that both of those scenarios are possible, but those are not the only explanations why you would feel that range of symptoms or lack thereof. So it could be, but honestly, you'll probably never know. I was really sick in March, and I'd just been in New York City, and I wondered the whole time, did I have COVID-19? And the truth is, I'll never know, because now that I've been vaccinated, the antibodies are there, and I just never know. But it could be that, or it could be some other explanation.
Yeah, some of these questions, I think it's going to be hard to find answers to, because you literally have to go back in time to kind of come back with answers about this. The next question we have up is about the J&J pause. So what about the J&J that's been temporarily paused as a result of blood clots and reopened? How safe is it now? And Rebecca, you touched on this quite a bit last week in your talk. You want to share some more details about that?
I definitely do, but let me give a shameless plug. If you haven't seen the second episode or the first episode, Dr. Sarah Cooper does the first one on biology. I did on public health. So the J&J pause is really interesting. And for me, it was fun to kind of explore the dynamics of this. So for those that didn't see or just want a really quick overview, the VAERS system is how people, any person, medical professional, can report issues with vaccination. So thrombocytopenia is excessive bleeding, and then you mix that with CVST, which is a blood clot in the brain, completely rare condition, especially those two combined. And what the pause was really for was to determine whether it was more widespread than the 6 out of 6.8 million cases. So out of 6.8 million vaccinations, I know Dr. Hotez said 1 in 100,000. I think he meant 1 in 1 million. That's what the figure.
Yeah, just to jump in there were more cases that came about after that initial pause, and the 1 in 100,000, that is probably an overestimate about how frequently, but it's probably somewhere between 1 in 100,000 and 1 in 250,000.
Okay.
People. Yeah, so there have been a few more cases.
Thank you for the update. And one thing that's really important for everyone to know is that pause gave the opportunity for clinicians to have updated treatment. So before, when a blood clot happens, a common treatment is heparin, which is a blood thinner. But the J&J pause allow clinicians to know that heparin is not the best treatment when this rare condition happens. And so now other treatments can happen, which means instead of fatal outcomes, it can be treatable outcomes. So the pause is really indicated for the medical community and also to make sure that this was safe. But this is not necessarily something that they're going in and changing the vaccine. They're changing the treatment so that way people have better health outcomes.
Thank you. And I think he also used the J&J pause to illustrate the fact that the vaccines are really, really safe, that even when there was a very slight instance of something going wrong with the person that was vaccinated, the pause was almost instantaneous, despite the fact that at that time it was just a 1 in a million in terms of the effect. And they stopped the whole vaccine to do a study to come back and make sure that everything works. So that's another way to validate that despite not having the full FDA approval, the vaccines are still super safe.
Absolutely. And
There
think
are
about like over-the-counter drugs or anything that's available in your pharmacy, things that are available to eat. There are more reactions from food and over-the-counter drugs than there are for this vaccine when we think about risk of driving in a car, risk of using a stove. When you think about relative risk, there's so much more risk in our daily life than there is in the vaccines. And I think that's a hard comparison for sometimes for people to make, but important.
Yeah, we have about 5 minutes left, and I want to take these couple of questions here. One, which said, I heard Dr. Hotez's response that the concern over infertility was traced back to a campaign by people who generally feel opposed to vaccines. But I don't think that answered the earlier question. Why should young women and others feel that we understand the long-term risks of the vaccination? And sort of Kathy is asking related to that question, is what about the long-term risks of the vaccination and how long is long-term? And I'm not sure we really have answers to these questions, but go ahead and give it a shot. Yes.
So I don't know if you want me, Sarah, I'll just jump in and then I'll let Sarah take the biology. Based on all other vaccinations in the United States, we know that there's an 8-week delay because within about 8 weeks, usually 2 to 3 weeks, that's when things that are going to go wrong have always historically gone wrong. And remember, people started getting this vaccine in 2020. So there's been a lot of time and indicators of long-term and especially women that have become pregnant and therefore given birth. So based on that data that does exist, if there was something, we would know about it by now, because this has been out as far as the clinical trials for quite a long time, long before January in the spectrum of that. So Sarah, what do you think about that?
Yeah, I mean, I agree with what you're saying, and I think that's totally scientifically accurate. I think if you kind of step back and listen to people's concerns, and this is something I sort of mishear sometimes too, when people say, I just want to wait and see what the effects of the vaccine are long-term, they're not talking about 8 weeks, right? They're talking about what's going to happen next year, what's going to happen 3 years from now, what's going to happen 5 years from now. Scientifically, we kind of know that the effects of the vaccine happen sooner, right? They happen closer to the actual vaccine. But I think public, when they talk about the long-term effects, they're talking about a much longer time frame. And so what I can say is a couple of things. One is that we don't have any indication that there will be long-term effects given what we understand about vaccine biology, right? Not just these vaccines, but other vaccines too, that those long-term effects, they just don't exist for vaccines. The second thing I would say is that if we're really concerned about long-term effects, and we compare people who've had the vaccine to people who've been sick, the long-term effects of being sick are clear, right? We see on average 10% of people have long hauler syndrome. We see people who leave a COVID infection, even a mild or moderate COVID infection, with kidney problems, heart problems, respiratory problems, and neurological problems that last for months after they get sick, right? We see the risk of death. We see the risk of serious illness. And those effects, if we're going to talk about long-term effects and in the range of months to years after infection or after vaccination, those are clear. The risks of these long-term effects happening in vaccines are much less there. But I will say I understand, right? This is new technology that we've been developing for decades, but is really just now been implemented. That being said, the good news that I was going to talk about, which I forgot to say at the very beginning, is that we've actually given 1 billion doses of vaccine in the world now. We passed that over this weekend, and 1 billion doses of all of the different types of vaccines that we have kind of worldwide. And that's a lot of people who've been vaccinated, and we haven't seen these effects that people were worried about, where the effects have come about with blood clots, with the risk of anaphylactic shock within the first 30 minutes after getting the vaccine. All of those things we've been able to catch, and we've been able to put into place protocols to keep people safe. So I understand, and I can even, I know we need to go, but I can even talk a little bit more about the fertility aspect. There is just no data showing any of these long-term effects, but we know a lot of long-term effects to being infected. And so when you're kind of thinking about relative risk, you need to think about what the relative risk is of getting infected. And that goes for young people too. That goes for all of us and all of our students who work at this college too. The long hauler syndrome is even more common in young people. And so these long-term effects are real.
All right. Thank you, Sarah and Rebecca, for that. So I want to end with a little preview about what's coming up next week at the education series. Next week, we have Dr. Elsa Villarino. She works at the county health office, the Santa Clara County Health Office, and she's almost, I believe, the second in command to Dr. Sarah Cody, who's our health officer. So she's going to talk to us a little bit more about what's happening here and what is allowed, what is not allowed, where can you get vaccines, and what are the follow-ups, and what are going to be the new guidelines. And we all are looking forward to this June 15th date, which our governor has indicated. So what happens after that? What can we expect after that, and so on. So please come back and join us for our final part of this 4-part series. So thank you very much for everybody who was here. And of course, this video will be posted on our website for you to watch at your leisure.